Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be going over care of the adolescent and the family. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already. And be sure to check out my website, nexusnursinginstitute.com. On there, you'd be able to reserve your spot for a next generation NCLEX review, both part 1 and part 2. You can sign up for private tutoring sessions, consultation sessions. If you're a current student and you're not studying for NCLEX, you're just trying to survive the program, I have audio lessons available for you. So be sure to check those out by going to my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, and Facebook. Also here, YouTube. My handle's the same everywhere, Nexus Nursing. Now, without any further ado, guys, let's get started. Okay, guys, so we're going to start with the early adolescent, 11 to 14 years old. Now, anything that I mention, I highlight, I underline, I have a star next to, or you see NCLEX, that means you need to know it, okay? So we're talking about the 11 to 14 year old. As far as growth is concerned, we start to see those secondary sex characteristics appear. We start to see, the peach fuzz in the boys. They start to get the deeper voice. For the girls, we see the development of the breast buds, the wider hips. As far as cognition is concerned, you see, I put NCLEX next to it. You need to know this. So this is where them establishing their identity. This is where it starts. They start to want to figure out who they are outside of the relationship with their parents, because up until now, their identity was connected to their parents in the family unit. But now they're trying to figure out who they are as an individual. Okay. Take a look what it says. It says their conformity to group norms that's important to them, and there's a decline in self-esteem. Why? Because they don't know who they are. They're just now trying to figure out who they are outside of that family unit. Relationship with parents, take a look. It says strong desire to remain dependent on parents while trying to detach. So they still have a strong desire to keep their parents happy and remain dependent on their parents, because remember, they don't have a job, they don't have money, they don't have a right to go anywhere. They're still attached to their parents, but at the same time, they want to detach. They want to have their own identity. Let's keep going. No major conflicts over parental control. You want to know why? At 11 to 14 years old, there's not going to be any conflicts over control, because guess what? They can't do anything. They don't have a job. They don't have their own money. They don't have a car. Car represents freedom. So we're going to see conflict over parental control when the adolescent can actually go places and do things. That's where we see the conflict, but not 11 to 14 years old. So that's important to know. Now, let's go over to middle adolescence. That is 15 to 17 years old. This is where, take a look. It says secondary sex characteristics are well advanced. So in early adolescence, where we just saw the peach fuzz, now you may see a full-grown mustache, right? They're developing a capacity for abstract thinking. They're starting to develop that capacity. So now if they want to do something naughty, they're starting to develop that capacity to think ahead and be like, okay, how would I get away with it? And if I get caught, what are the possible consequences? Now, this capacity for abstract thinking is limited because, look, they're just starting to develop it, okay? They're self-centered and narcissistic. These are the high school years where they're concerned about how they look and everything's about them. They have a rich fantasy lifestyle, and it's a fantasy because guess what? They don't have a job. And if they do have a job, they're not making much money anyway, right? So in their mind, they're ghetto fabulous. They have a rich fantasy life. Let's keep going. Low point in parent-child relationships. Why? Because they're more concerned about their friendship group. Remember, they figure out who they are. Their identity is figured out through their socialization, through their friend group. So the friends become more important than the family. So they're not going to want to have dinner with the family. They'd rather be out with their friends. They have a greatest push for emancipation, disengagement. Why? Because they really want to be their own person. Number one, make that bigger for you. And number two, again, the friends are more important. Look at this. Acceptance by peers, extremely important. They have a huge fear of rejection. Moving on to late adolescence. Let me move this for you. In late adolescence, that is 18 to 20 years old. The structure and reproductive growth is almost complete. We see that the body image and gender role definition is nearly secured. Mature sexual identity, they are now pretty much secure in their identity, socially speaking and sexually speaking. They have an increase in self-esteem. And I want you to think about that. Why would we see that increase in self-esteem around 18 to 20 years old? Because they don't have that pressure of high school. 18 to 20 years old, they're either graduated or about to graduate, right? And so now they have more security in who they are, and they really don't have that type of pressure where they're in that fishbowl. We're seeing them being comfortable with their physical growth. Emotional and physical separation from parents have completed. Why? They've graduated or they're about to graduate. They're about to go to college. They're about to go to the armed forces. They're about to move out of the home. Emancipation is nearly secured. There's not much more of that fight for independence. They pretty much have gotten it. Peer group recedes in importance in favor of individual friendship. So back in middle adolescence, when it was the adolescent was 15 to 17 years old, and acceptance was so important that they wanted everyone to like them. They wanted to be just like everyone else. Now they're secure in themselves. And instead of having, all of these friends, which were important to them in middle adolescent, just having one or two very good friends is more important to them. Okay, they become interested in dating for a romantic partner. And look, more constancy of emotion. Why? Their hormones aren't up and down like they were in early and middle adolescence. Okay, let's move on. I'll give you guys a second. If you need to take a picture of this, go ahead. Again, everything I have a star, underline, or NCLEX next to, you're going to see that test question somewhere. Make sure you know it. Okay, moving on. Give me a sec, guys. Okay. So box 35.1, it says Tanner stages describe the stages of pubertal growth and are numbered from stage 1, which is immature, to stage 5, which is mature for both males and females. You need to know that. Stage 1, immature. Stage 5 is mature for both males and females, and we're going to be going over this. But I want you to pay attention, guys, because we're seeing them talk about Tanner stages in this box. And then the box right below it, they talk about the maturational sequence or maturational changes, these Tanner stages, which we're also about to see on the next page. Remember what I said to you before. I say this all the time. Whenever you're studying and you see the text is talking about something several times, you're seeing it in text, you're seeing it in a box, you're seeing it in illustration or figure or diagram, it's going to be a test question somewhere. It's very important. You need to know it. So let's take a look at box 35.2, where it says usual sequence of maturational changes. For girls, the first thing you're going to see are breast changes. And that's why I put first next to it. Okay. You guys can look at everything else on the list, but most importantly, you need to know those breast buds. You see that first for the girls. And for the boys, enlargement of the testicles. That's what you see first for the boys. Take a look down here. It says right here, I put a star next to it, the initial appearance of menstruation or menarche, that's what it's known as, occurs about 2 years after the appearance of the first pubescent changes. 2 years after. So you see those breast buds, and about 2 years after, we should see that first menstruation. Ovulation and regular menstruation periods usually occur 6 to 14 months after menarche. Look up here. It says early puberty is also characterized by the initial appearance of pubic hair. Physical growth and during puberty, along with increases in reproductive hormones and sexual maturation, a dramatic increase in growth happens. So we see them getting taller. Most of this growth of skeletal muscles and internal organs, this occurs about 24 to 36 in the 24-36 month period, the adolescent, this is what's known as the growth spurt. So that rapid growth in height. Now let's take a look at the next page. This is where they go over the Tanner stages. Again, I'm telling you guys, you're going to see a test question somewhere. You better know it. Look what I wrote here. No stages, know all of them. And I put a star next to the ones that are usually most likely the test question that you get, but I'm not your instructor. You can get anything. Stage 2, we see a breast bud stage. That's important to know. Take a look at this development stages for girls and boys. Another one that's important to know. The initial enlargement of the scrotum and testes. That's what we first see for the males. Let's go over cognitive development, emergence of formal operations, Piaget. Whenever it comes to Piaget, we're talking about cognition. We're thinking about the thought process, okay? So take a look at what it says here. It says cognitive thinking, cognition, how you think. Cognitive thinking culminates with capacity for abstract thinking. This stage, the period of formal operations, is Piaget's fourth and last stage. Adolescents are no longer restricted by the real and actual, which was typical of the period of concrete thought. Now they're also concerned about the possible. So at this stage, they don't have to have something concrete in front of them for them to think about all of the possibilities. They can actually think ahead. Next, let's talk about Erikson. Okay, so you see when we were talking about Piaget, we're thinking about cognition, how you think. Well, whenever we're talking about that theorist Erikson, what we're talking about is psychosocial development. Okay? Erikson, psychosocial development. And you'll see on the side, I wrote here role versus role confusion, because that's what it's all about when we're talking about psychosocial development in the adolescent. It's them figuring out who they are, their identity versus role confusion. Take a look. It says during this time, adolescents are faced with the crisis of group identity versus alienation. In the period that follows, individuals strive to attain autonomy from the family. They want independence from the family and develop a sense of personal identity as opposed to role diffusion. A sense of group identity appears to be essential, that means very important, to the development of a personal identity. All of that to say, at this stage of their life, the adolescent, what is most important to them is their peer group. Why? Because the milestone that they have to overcome is figuring out who they are, their identity, and they figure out their identity through socialization, through their peer group. So they have to start detaching from the family unit, from the parents, and establish their own identity through their peer group, through socialization. And here's what's so crazy. Around this age, they're trying to figure out who they are. They want to look exactly like their friends. They don't want to look any different because they're very self-conscious. They don't want to be made fun of. But at the same time, even though they want to look exactly like everyone else, they want to look different. They want to be different. They want to have their own identity. And so this is a conflict that we see in the adolescents. Let's keep going. Group identity. It says for adolescents, as adolescents, I'm sorry, guys, you know I can't speak. Forgive me. As adolescents establish identity within a group, they also attempt to incorporate multiple body changes into a concept of the self. Body awareness is a part of self-awareness. We may start to see, some adolescents may want to get a tattoo. Some may want to get a piercing. We'll see different types of maybe enhancement or things that the adolescent will want to do to set themselves apart. Nursing guidelines for interviewing adolescents. Ensure confidentiality and privacy. You want to interview adolescent without the parents, right? So what you're going to do, if you have a physical assessment, you have a physical you have to do on the patient, you do your physical, but when it comes to asking them questions, guess what? Mom and dad, sorry, you got to wait outside. Why? That adolescent has to trust you with information because you can't help them unless you have the correct information. You have to ensure privacy. However, you have to let that adolescent know, you have to tell them the truth. If there is something that will endanger them, you may have to share it with other members of the healthcare team. Okay? You're going to explain the limits of confidentiality. Take a look. Legal duty to report physical or sexual abuse, or to get others involved if the patient's suicidal. And right here, I wrote, don't lie. Don't lie and tell them you're going to keep their secrets, because guess what? If the secret involves them being suicidal, physical abuse, anything that you have to get the authorities involved, you have to get the authorities involved. So don't lie to them. You have to tell them the truth. Maintain objectivity. Avoid assumptions, judgments, lectures. You know, we don't do that in nursing. You always want to ask open-ended questions when possible, because we want the patient to be able to express themselves. Matter of fact, the only time we want to be asking closed-ended questions is in 3 situations: suicide, abuse, or quick assessment. Patients going into surgery, you need to know right away, you know, are you diabetic? Have you had alcohol in the past 48 hours? Things like that. Are you on anticoagulants? Things like that. You're going to begin with less sensitive issues and proceed to more sensitive ones. Why? Because if you dive right into the sensitive issue, they're going to clam up. So you're going to start asking just general questions and then zone in on the more sensitive issues. Use language that both the adolescent and you understand. So don't use medical jargon. And restate. If they say something, repeat back what they said to you in different words, just to make sure that you understand what they're saying, and allow them a chance to either correct you or confirm, yes, this is what I'm saying to you. Emotional well-being. Surprise, surprise. Their emotions fluctuate when it comes to adolescence, right? Adolescents facilitate their emotional states between considerable maturity and childlike behavior. One minute, you know, they're emotionally mature, and the other minute they're acting like a child. One minute they're exuberant and enthusiastic, and the next minute they're depressed and withdrawn. Unpredictable but essential normal mood swings are common during this time. It is very common. So if you get a test question about mom or dad concerned about their emotional lability, you have to explain to the parents that this fluctuation is normal. Teenagers are better able to control their emotions in later adolescence, around 18, 19, when they can approach problems more calmly and rationally. And another reason for this, guys, is that their abstract thinking has been solidified. Intentional and unintentional injury. MVAs, motor vehicle crashes, are the highest single greatest source of unintentional injury and death among young people. Why? They're just learning how to drive. They're getting that independence. But remember, that part of their brain that develops for decision making is not fully functional. And so very often, most teenagers, they do think they're invincible. And so they'll take unnecessary risks. Suicide, a form of intentional injury, is the second leading cause of death among all adolescents in the US. Homicide is the third leading cause of death, many involving firearms. Many adolescents report easy access to a gun. Their propensity for risk-taking. Remember, I told you we'll see a lot of risk-taking behavior. The propensity for risk-taking behavior plus feelings of being indestructible makes adolescents especially prone to injuries. The leading cause of injury-related morbidity among adolescents include vehicular crashes, firearms, drowning, poisoning, burns, and falls. That word, morbidity, that means illness. So there's mortality, death, and morbidity, illness. So when we're talking about these, we're talking about morbidity, okay? Some of the developmental characteristics of teenagers and injury prevention suggestions are outlined in box 35.3. Now let's talk about dietary habits. Notice right next to dietary habits, what did I write? Social acceptance is number 1 to them. So before anything else, they want to be accepted by their group friends. So whatever their friends are eating at that time, that's most likely what they will ingest, okay? Growing independence, the need for peer acceptance, concern with physical appearance, and an active lifestyle may affect eating habits, food choices, nutrient intake, and nutritional status. Excess intake of calories, sugars, fat, cholesterol, and sodium are common around the adolescent age. But why? They're eating chips and cookies and, cupcakes, things that are fast. These dietary patterns could result in increased risk for obesity and chronic diseases and some cancers later in life. Hypertension. With increasing levels of obesity, there have been reports of increasing incidence of hypertension among adolescents. Screening for hypertension and associated risk factors should take place every year beginning at the age of 3 years old. And then this short little insert about hyperlipidemia, that's basically high cholesterol. It says a restricted fat diet, lifestyle modification, exercise, and weight management is the most important. That's important nursing interventions that you're going to teach. Decrease fat in the diet. And let me tell you something. When it says restricted fat, sometimes some some food labels may not say fat, but if it says rich, if it says creamy, if it's oily, if it's greasy, it's high in fat, okay? So low fat, exercise, and weight management are all important to decrease high cholesterol or hyperlipidemia. I'm going to skip over adolescent immunizations just because I already have a video on adolescent immunization. So if you guys haven't watched it yet, go to my pediatrics playlist and you'll see a video on adolescent immunizations. Be sure to watch that. All right. So anyway, let's take Let's take a look at box 35.4, areas of stress in the adolescent. And I'm not going to go over them, but all of them, I'm going to go over the most important ones. I have a star next to body image. They're very concerned about body image. It is very important that you protect that, you protect their privacy, you close the curtain when you have to do any assessment. They're very concerned about how they look versus their social group, their relationship with parents. This is another area of stress because this is the age where they're trying to establish their independence from their parents and relationship with peers. They want to look just like all of their friends, but at the same time, they want to be an individual and they want to look different. And so that is a conflict. All right, conditions affecting the male reproductive system. We'll start with a varicose. Varicocele. A varicocele, this is a pathologic enlargement of the testicular vein that's associated with impaired spermatogenesis and infertility. So when it comes to varicocele, they're treated either by surgery or embolization because guess what? It can cause infertility. Epididymitis, this is inflammatory response of the epididymis. Clinical presentation is slow and insidious. That word insidious means it creeps up on you, okay? It's slow and insidious. We're going to see unilateral, that means one-sided, unilateral scrotal pain, redness, swelling. Associated symptoms include urethral discharge, dysuria, fever, pyuria. Treatment's going to be analgesics for the pain. Scrotal support. I underlined it, I highlighted, I put a star next to it, and I wrote NCLEX next to it. NCLEX loves to ask about it, okay? Scrotal support is very important. Usually take a hand towel, roll it up, and put it under that scrotal area for support, bed rest, and of course, antibiotic therapy. Pediatric testicular torsion is a surgical emergency. It requires a thorough history and physical exam. Neonatal testicular torsion often presents as a hard mass found on routine examination. Why? Because that scrotal area is supposed to be soft. Surgical management typically includes orchiectomy, removal. In severe torsion, the organ becomes swollen, painful. The scrotum becomes red, warm, swollen, edematous, appears to be immobile or fixed as a result of spasms of the cremasteric fibers. A prompt diagnosis and definitive surgical management are essential in males of any age to preserve the affected side. In patients, when you have a high clinical suspicion, emergent surgical management is warranted. Gynecomastia, those are male boobs. Okay, could be bilateral or unilateral. It's breast enlargement and occurs frequently in boys during puberty. And that just has to do with the hormonal changes. And sometimes if the adolescent, the boy is a little overweight, you may see this as well. Patient information is to obtain from the history includes duration of symptoms, the presence of nipple discharge or overlying skin changes, reports of below normal prenatal androgen effects, testicular swelling or masses. A careful genital urinary exam is also of particular importance. Attention should be paid to the Tanner staging. Again, guys, make sure you memorize it. You're going to see it as a test question. Attention should be paid to the Tanner staging, testicular volume, and masses or irregularities along the testes. Administration of testosterone has no effect on breast development or regression, and it can actually make the condition worse. Obesity. Currently, the body mass index measurement is recommended as the most accurate method for screening children for obesity. This is what's important for you guys to know about this. BMI at the 95th percentile or greater is class 1 obesity. If the patient's between 85 to 95%, they're considered overweight. But once they hit that 95th percentile, they're obese. All right, therapeutic management. The best approach to the management of obesity is a preventative one. Whenever we're talking about prevention, guys, we're talking about what? Type 1 preventative measures, okay? So teaching, education, early recognition and control measures are essential for the child or adolescent before they reach the obese state. We want to prevent rather than treat. Currently, the only treatment recommendations for children are diet, appropriate diet, fruits, vegetables, exercise, behavior modification, and in some situations, pharmacologic agents such as orlistat. Diet modification is an essential part of weight reduction programs. You can exercise as much as you want, but you have to also eat appropriately as well. Children and adolescents should avoid fad diets. No no South Beach diets. All those fad diets should be avoided. High fiber foods and avoiding highly refined starches and sugars decrease the caloric intake. You can encourage that patient to keep a food diary because sometimes it helps. If they have to write down what they put in their mouth, they'll think twice. Okay, is this a healthy decision? The goal is to encourage the individual to make healthy choices in food selection and to discourage using food by habit or to appease boredom. Take a look at box 35.7. Box 35.7 recommended behaviors for preventing obesity. Limit the consumption of sugar-sweetened beverages, like what? Sodas, juices. Consume recommended quantities of fruits and vegetables. Why? They're high in fiber. They're going to help get rid of those things we don't want in the vessels, like the lipids, the fats, the oils. Limit screen time to no more than 2 hours a day. Why? You need to get out moving. Eat breakfast early. You have time to burn it off. And I put a star next to it. Make sure you know it. Limit eating at restaurants, especially fast food. Have frequent family meals in which the parents and you eat together. That gives you a chance to have a healthy meal and also to talk with the child. And also limit portion sizes. One of the things you can encourage the parents is to provide smaller plates to help limit the portion sizes. Okay, anorexia nervosa and bulimia, read that on your own. I'm not reading all of that, but I'll tell you some important things you guys got to know about anorexia and bulimia. Okay, so when it comes to anorexia, that's when the patient just is not eating enough food. They don't have enough nutritional intake to sustain them, right? They're going to be at high risk for nutritional, fluid, and electrolyte imbalance. They tend to be very, very thin, right? And what tends to be the cause very often, or of high contributing factor to anorexia, because the typical anorexic patient tends to be a female adolescent that is a high achiever. And so what happens is, well, let me back up. They're a high achiever with a mom or dad, usually a mom, that's just overbearing. So what happens is she feels like her whole life is controlled. She's captain of the cheerleading squad. She's president of student government. She's president of all these clubs. She's a straight A student. There's a lot of pressure on her in academics. There's pressure on her to get into a good college. She feels like she has no control over her life. Her parents are on her about everything, typically the mom. Usually this is what studies show, right? And so she feels like she has no control over her life whatsoever. But guess what? There's one thing she controls: her mouth, what goes into her mouth. And so that's where the adolescent patient gets that sense of control, by not eating, okay? The bulimic patient is a little bit different. The bulimic patient, instead of being severely underweight like we see the anorexic patient, the bulimic patient is usually at their target weight, or just a little bit above weight, or a little bit below weight. But they're more close to their target weight, definitely, versus the adolescent patient, right? And with the bulimic patient, their problem is not that they're not eating at all. Their problem is, once they get stressed, they start eating everything under the sun. They start to binge. And then what happens is they binge, and then they feel guilty. They feel embarrassed. Why did I do that? And then they purge. So it's a cycle of binging and purging, binging and purging. And so that's what we see with the bulimic patient. Now, this bulimic patient, they may not be at high risk for nutritional deficiency as an anorexic patient, because the anorexic patient isn't eating at all. The bulimic patient is. They're binging, then they're purging, but they're going to be at high risk for fluid and electrolyte deficiencies because of all that purging. Okay, so you guys can read all of that on your own. But let's take a look at 35.9 important things you guys need to know about the clinical manifestations of anorexia. Remember, anorexia, this is where they're not eating at all. They have severe and profound weight loss. They're going to be very thin. Sinus bradycardia, they're going to have cardiac issues. Intolerance to cold, dry skin, brittle nails. They don't have the nutrients to keep, the skin nice and moisturized and the nails strong. They're going to have appearance of lanugo hair. This is a famous NCLEX question. Make sure that you know that. Okay. Who do we see that lanugo hair on? We usually see that on those newborns. Thinning hair, fatigue, lightheadedness. Take a look at box 35.4, and it goes over anorexia versus bulimia characteristics. The ones I have a star next to, make sure you know. Okay, so as food is concerned, remember, the anorexic patient, they won't eat, so they turn away from food to cope. That's how they get their sense of control. Where the bulimic patient, when their anxiety grows, they feel like they're losing control. They do the opposite. They turn to food. They start to binge. As far as behavior, the anorexic patient, they tend to be the model child. They tend to be obsessive compulsive. They're high achievers. Everything has to be perfect. Where with bulimia, they often act out. They're impulsive. And how are they impulsive? By binging. Control. With the anorexic patient, that's how they gain control, by not eating. They have very rigid standards. But bulimia, they lose control. They're eating everything under the sun. As far as weight, the anorexic patient, they're going to be below the 85th percentile. Okay. And when I say below the 85th percentile of the expected norm, but the bulimic patient, look, they'll be within 2.3 to 7 kilograms, about 5 to 15 pounds of the normal body weight. It may be a little bit above, it may be a little bit below, but they're more closer to the expected body weight than the anorexic patient. Therapeutic management. Number one, always, 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 reinstitution of nutritional or reversal of severe state of malnutrition. Okay, now, If you get a test question about anorexia or bulimia and they're asking you what's going to be priority, fixing the nutritional status and the fluid electrolytes is always going to be a priority. But if it's a multiple choice and you have both nutrition and fluid and electrolytes, your priority is always going to be fluid and electrolytes. And I'm going to tell you why. Your priority is always going to be what's going to kill your patient the fastest. And guess what? Fluid electrolyte deficiency is going to kill you faster than a nutritional deficiency. You can go weeks without food, but you can only go days without fluid and electrolytes, right? So fluid and electrolytes are always going to trump nutrition. Okay, what are we talking about? Nursing alert. About suicide. A history of a previous suicide attempt is a serious indicator for possible suicide completion in the future. That is one of the, if not the top predictors of suicide attempt. Have they tried in the past? Look at this nursing alert. Parents must ensure that their children, especially those who are depressed, have poor problem-solving skills, or use drugs, do not have access to firearms. Those firearms need to be out of the home. And if they absolutely must be in the home, they need to be locked away where the adolescent cannot get to them. Warning signs of suicide. I put a star next to the most important ones you need to know. When that adolescent wants to give away cherished possessions. When they talk about their own death or desire to die. When they remain distant, sad, remote. Remember, the adolescent, it's normal for them to have fluctuations. They're happy, then they're sad. They're happy, then they're sad. But if they're remaining in that sad state, they may be depressed, okay? So if you're seeing constant distance, sadness, remoteness, they have a flat affect. It's like a mask. They're not happy. They're not showing, a grief. It's just like a mask. They have a flat affect. They describe themselves as worthless. You want to know what depression is? Depression is anger, hostility, resentment, turned towards self. Okay? They feel like they have no value. They're worthless. They bring no value to the world. And so guess what? It doesn't matter if they're in the world. Okay? Feelings of worthlessness. Or look at this. This is important. I highlighted it. I put a star next to it and I put NCLEX next to it. Sudden cheerfulness following a deep depression. So this patient has been depressed. Now, all of a sudden they're happy. Why do you think they're happy? Because they came up with a plan. They finally figured out how they're going to successfully harm themselves. And that's why they're happy. They're happy because to them, there's a light at the end of the tunnel. Okay. So if you see sudden cheerfulness after, a bout of depression, you better be suspicious. You better put that patient on a one-on-one watch. Nursing alert. Adolescents who express suicidal feelings and have a specific plan should be monitored at all times, one-on-one. They should not have access to firearms, prescription or over-the-counter drugs, belts, scarves, shoestrings, sharp objects, matches, or lighters, anything that they can harm themselves with. No threat of suicide should be ignored or challenged. The improvement of attitude, all of a sudden they're getting cheery, may mean that the adolescent has made the decision and found the means to carry out the threat. And I put an NCLEX next to it. That's a famous question. Make sure that you know it. And when I say this patient needs to be on one-on-one supervision, even to the bathroom. You see what I wrote here? Even to the bathroom. Oh, you have to go to the bathroom? Let's go. You have to go to the bathroom? You're going with that door open. You have to keep an eye on that patient. Okay, so if you suspect this patient's suicidal, the first thing you're going to do is ask them directly, are you having thoughts of harming yourself or anyone else? Ask them directly. Don't go around the bush. Because many patients who are suicidal, they want someone to ask them. They want to talk about it, but no one's ever asked them before. You ask them directly. And if they say yes, your next question is you need to find out their means. Do they have a plan? And the way you find out if they have a plan, you ask them, how do you plan on doing it? Do you have a plan? When they're telling you their plan, you want to know why you want to know if they have a plan. You want to know if they actually have access. So if they tell you, oh, I plan on shooting myself, the next question is, do you have a gun? Do you have access to a gun? And they say, yep, my grandpa keeps his gun right under his bed on the left side. Oh, they've thought about this, right? But if that patient says, yes, I want to harm myself, you ask them, do you have a plan? They say yes. And you ask them how. How do you plan on doing it? The reason you're asking them how, you want to find out if they have access. And they tell you, oh, I plan on jumping off of Mount Everest. And they live in Florida. So, I mean, yes, they possibly may have access, but it's not immediate access. You understand what I'm saying to you? So you're always going to ask them if they have a plan. Do they plan on harming themselves? If they say yes, do they have a plan? You want to know what the means is, and access. You want to know if they have access to the plan. Oh, and that's it, guys. That is the end of this video. Please let me know what you thought about this video in the comment section. Let me know if you'd like me to create a Kahoot regarding this topic, or maybe a video like the videos I make on Sundays, 1 p.m. Eastern Standard Time, the Q&A. Let me know what you thought about this video in the comment section. Please don't forget to like and subscribe. Thank you so much for watching this video. You guys will catch me on the next video.